The following podcast is part of a certified educational activity titled Modern Diagnostics and Targeted Therapy for TRK Fusion Cancers, Pathology-Oncologist Collaboration in the Era of Precision Medicine. Access the entire activity and complete the post-test at peerview.com/DMK860. Downloadable slides and practice aids are also available.
Hello, and welcome to Modern Diagnostics and Targeted Therapy for TRK Fusion Cancers. My name is Dr. George Dimitri from the Dana-Farber Cancer Institute and Harvard Medical School. During this CME presentation, we'll focus on the ever closer and ever more important partnership between pathologists and oncologists, particularly in this era of precision medicine and tumor-agnostic therapy directed against gene fusions. I'd like to now present my colleagues, and I'll let them introduce themselves. Let's start with Dr. Alex Drillon from Memorial Sloan Kettering.
Thanks very much, George. I'm Alex Drillon, the Chief of the Early Drug Development Service at Memorial Sloan Kettering Cancer Center in New York. Glad to be here.
And Brian?
Good morning. Nice to be here. Thanks for inviting me to participate in this activity. I'm Brian Rubin. I'm the Chair of Pathology at the Cleveland Clinic, and I'm the Director of Soft Tissue Pathology.
Thanks to both of you. Welcome to the discussion. We really want to have this be an interactive discussion, but let me kick this off, and let's start by looking at some of the biology behind the TRK gene, the TRK proteins, and the diagnostic principles of capturing the gene fusions of the gene, which is actually called NTRK, not TRK. So this is confusing to everybody, but if we really go through this, hopefully it'll make sense by the end. And the fundamental importance of diagnosis in medicine, especially cancer, can't be underestimated. We need a great diagnosis, the most accurate diagnosis, before we as medical oncologists or as surgeons or radiation oncologists think about treating our patients. So how do we look for key oncogenic drivers like NTRK gene fusions? To start off, let me go through what some of the somatic gene alterations or genomic alterations really drive cancer. We hear a lot about mutations, but there are a number of alterations in genes that cause cancer. Mutations are the ones that are in the public eyes and ears, and we have point mutations or short insertions or duplications of sequence or whole bits where deleted sequences can come out that change the reading and the sequence of the DNA. And that, of course, translates into the sequence of the RNA and the sequence of the protein. So those are mutations known as point mutations or indels for insertions or deletions. And those things typically activate some of the genes on the right. Epidermal growth factor receptor, KRAS, commonly mutated by point mutations, BRAF, my favorite, KIT is often mutated that way. So those are alterations in the sequence per se. We also know a lot about copy number alterations, right? You can have amplification or too many copies of a gene, which everybody knows about from HER2 amplification. And now we're increasingly hearing about MET amplification and other things like MET, where it can actually skip its reading. You can have different exons that get skipped, causing a mutant protein, which is not a copy number alteration. So genes aren't always altered in the same way. You can have problems, let's say in MET, because of amplification, or problems with the sequence. And then we're here to talk mainly about gene fusions. The granddaddy or grandmommy of all gene fusions was BCR-ABL, of course, which activates the ABL kinase. We know all sorts of things now about the ALK fusions, and ALK is very important as a target in lung cancers. And here we're here to talk about NTRK fusions. NTRK is also important in many different kinds of cancers, as my colleagues will talk about as well. Now, just to mess us up, the basic scientists named the genes one thing and the proteins another thing. We have 3 NTRK genes in humans, NTRK 1, 2, and 3, which when translated turn into the TRK proteins, TRK A, TRK B, and C. So these cancers that have fusions can either be called NTRK gene fusion cancers or TRK fusion cancers. And different people use the terminology at different times. Brian, I don't know, in pathology, is there any standard that pathologists like to call these, or is this just dealer's choice?
Oh, no, we use the gene names and we call them NTRK 1, 2, and 3.
So that's important because oncologists commonly look at reports, and the reports from pathologists may be report coming from, let's say, reference genomic laboratories. So keep that in mind and don't be confused of it. There's a really nice paper published back in 2014 that talked about this so-called long tail of kinase fusions across cancers, which meant that when you go through publicly accessible databases like the Cancer Genome Atlas, you can find all sorts of genes with fusions. Here we have ALK, BRAF, EGFR. You go down here, there's RET fusions, and in the box here are NTRK fusions. And at the bottom, you'll see the variety of cancers where fusions can be detected, from thyroid to glioblastomas to lung to adenocarcinomas of the GI tract or the bladder and lung, etc. It just goes on. And if you build out, let me just expand that red box. Here are the NTRK fusions that were found in a wide variety of different kinds of cancers. As I say, from head and neck squamous cell cancers to invasive breast carcinomas and gliomas. So this is a challenge. Most of us think of specializing in academia in one cancer type, but here's a gene that affects many different cancer types. And we use the term sometimes tumor agnostic therapies because if you've got a TRK fusion, as you'll hear from Alex Drillon later, this can have very important impact in many different kinds of cancers. So we need to have that nodal point between the type of cancer and the type of fusion, and then maybe we can synergize with one type of therapy. Now, we all know how gene fusions can lead to activation because we all learned about this in medical school around BCR-ABL, right? BCR-ABL is a little bit different because it's an intracellular kinase. What we often think about here on the left side, we have a receptor tyrosine kinase, where the ligand will bring together two receptor kinases that are poking through. This is the cell membrane, poking through the cell membrane. The ligand brings them together. The tails talk to each other and set up the downstream signaling cascade. Okay, so that's normal physiology. What you see in fusions, though, as you know, is that things will break apart and this will join that. And basically you can have a reciprocal change as well to keep it balanced. And what you see, though, in the oncogenic side of this is that the upstream side will be the fusion partner. The downstream side is the kinase domain, which now has lost the controlling part. The upstream part of the protein, when this is translated, is lost, so the kinase is uncontrollably activated. This is what happens here in a very simple diagram here, where you've got, in a weird way, the receptor tyrosine kinase flipping on its side, which it doesn't actually do, but where you've got intracellular kinases like BCR-ABL, they simply activate by themselves, stimulating downstream cascades. And that's exactly what happens with TRK kinases. They lose their upstream side, a new kinase activity is formed that's now not controlled, and this chimeric protein can dimerize and cause all sorts of mess, and that's the oncogenic signaling. So we see this as a theme in cancer biology, that fusions do tend to be very, very important, especially when you've got a fusion that leads to inactivation of any kind of control for a kinase. Now, where do you see TRK fusions? In so many ways, this goes back to the 1980s, where occasionally strange diseases that medical oncologists on the adult side just don't hear about, like infantile fibrosarcomas. When people were seeing a lot of translocations in various types of sarcomas, this one came out as one that had a TRK fusion gene that popped up. And that was interesting. And then that same fusion came out in other kinds of unusual tumors, like secretory subset of breast carcinoma. It's a specific morphology that Brian can talk about from a pathology side. But this one as well, more than 75% of them will have this TRK fusion. So these unusual types of cancers have a high incidence of TRK fusions. As you go to the left side, though, you see a bunch of more common tumors to some extent, like papillary thyroid cancers, or even gastrointestinal stromal tumors, which usually have KIT or PDGF receptor alpha mutations. But the ones that do not have that mutation, and the ones that do not have SDH or succinyl dehydrogenase mutations, we haven't known for a long time what drives those, but a small number of those will actually have TRK fusions as well. We're also seeing a lot of spindle cell type sarcomas that are otherwise undifferentiated that will show up in young adults and often pediatrics that have TRK fusions. So these are more uncommon. They're not the predominant side, but somewhere between 5% up to a quarter of these types of cancers will have TRK fusions as well. And then there are many more common tumors like lung carcinomas, which have an even lower incidence, perhaps 1% or so. We can talk about that later. These are some of the more uncommon types of common cancers. So if you've got a disease like lung cancer, even 1% could be a significant number of people, and we don't want those patients to go missed. That's really a potentially significant medical loss for any individual patient. And we can talk about these various kinds of tumors in a bit after Dr. Drillon goes down and tells us more about the activity of some of the TRK fusion inhibitors. But let me pass the screen sharing over to my colleague, Dr. Rubin, to talk about how a pathologist can detect TRK fusions in practice.
Okay, thanks very much, George. So as George mentioned, a lot of the cancers that we're interested in have TRK fusions at a low frequency. There's some of them that have them way more commonly, like infantile or congenital fibrosarcoma. And so what are the strategies that we use in pathology, and specifically molecular pathology, well, and to some degree anatomic pathology, for detecting these TRK fusions? Because at the end of the day, we want to identify the cancers that have TRK fusions so we can get them to the oncologists, such as Alex and George, so that they can treat patients, because we know that these TRK fusions are going to respond at very high frequencies to specific TRK inhibitors, which will be discussed a bit later. So let's get going and talk about how we detect TRK fusions. So the first mechanism or method that we use is immunohistochemistry. Now, you can take an approach of using single antibodies to the different TRKs, or you can use a pan-TRK inhibitor cocktail or pan-TRK immunohistochemical cocktail, and that's what most of us do. And so this is a good way to screen. And so in labs where you don't have access to genetics, or in the case where you want to just screen neoplasms, for instance, that have a low incidence of TRK fusions, immunohistochemistry can be quite useful. There's actually a variety of different patterns that can be seen, everything from cytoplasmic to membranous, and it's all relevant. Our experience actually with TRK neoplasms is still relatively new, and so I would count any kind of positive as a positive in a screen. So I'm just looking for either anywhere from faint to very strong staining. And then, of course, we can use genetics to verify. The downside of immunohistochemistry is that you don't know the fusion partner. However, it is very sensitive for picking up TRK fusions. But they do, again, we'll get to this later, but it's good to validate them with a genetic tool. So there's been some evidence that's been presented. The paper that everybody likes to talk about is Heckman's paper, and they used a pan-TRK monoclonal antibody from Abcam. They looked at 23 available cases that were already genetically proven to be TRK fusion cases, and 20 cases that were known not to have TRK fusions. And IHC was concordant with an Archer-based platform, which is a genetic platform which uses reverse transcriptase essentially to look at RNA for gene fusions. And they found was concordant in 21 of 22 cases with a sensitivity of 95.2% and a specificity of 100%. I will emphasize that this is a small study. We need much larger studies, and in fact, in my own practice and in larger studies, we're finding that while sensitive, it's not quite as specific as we would have been led to believe by this particular study. However, it is a good study, and it serves as the basis for things moving onward. And there have been other studies in the literature now as well. Let's look at FISH. So FISH is a good technique. It's rather specific, so you're really looking for just TRK fusions now, and you have typically break apart probe sets to look for TRK gene rearrangements, which would indicate that there's a fusion. This is useful really in the setting where you have a tumor that has a high incidence, a high prevalence of having TRK fusions. For instance, congenital fibrosarcoma in the sarcoma world. We know over 75%, and really even more than that, of those lesions are going to have fusions. Secretory carcinoma of breast would be another example where we know most of them have fusions. You're really just confirming the diagnosis by using FISH. Here we can see some examples of a couple cases. And so on the left, we've got what looks to be a colon cancer. And you can see it's at 2 different magnifications. And you can see that this is obviously positive, as shown by the brown stain. That shows pretty diffuse and relatively strong positivity. On the right, we've got a FISH, example of FISH. It's a break-apart probe set. And so when the red and green, what you do is have a red probe on the 5 or the 3' end and a green probe on the other end. When it's broken apart, you can see individual signals, as shown here by red or green signals. When you have the wild type non-rearranged gene, red and green are in proximity, and you end up with a yellow signal. And I think you can see both of these here on that. The take-home point here is that these are techniques with faster results, such as IHC and FISH, may be useful in cancers in which the likelihood of a TRK fusion is high. And as I said earlier, I think immunohistochemistry is really good as a screening tool. So let's also talk about next-generation sequencing. And so the beauty of next-generation sequencing is it's now, with modern techniques, most people have access to multiplexed NGS in the RNA setting. And so what that allows you to do is test for a really very large variety of rearrangements and fusions simultaneously. And we have this at the Cleveland Clinic, where we've got a modified panel from Archer, and we can look at a vast number of gene fusions simultaneously. And so it's nice because if you're trying to look for TRK fusions, for instance, we have NTRK 1, 2, and 3 on our panel, so we can detect all those fusions. But in addition, we've got a variety of other things. And so it really harnesses the power of NGS. And it's nice that it's multiplex so that we can detect a variety of things. The other nice thing about NGS is we always detect the fusion partner. The Archer system is great because it's agnostic to the partner, and so we don't need to know what the partner is. We random prime essentially off the NTRK or off the partner gene in pairing with NTRK to generate each fusion. And so we can just, it's a discovery tool as well as a tool to validate the known TRK fusions. For instance, ETV6 NTRK3 is the most common fusion across the board, and we picked that up. I would say the negatives of NGS is that not everybody has availability of NGS. It's certainly present at most academic centers like the clinic and like Sloan Kettering and Dana-Farber. But if you don't, you can always send it out. But then it is also time consuming. It takes typically a minimum of 10 days. Most places are between 10 and 21 days to get the results back. And it's rather expensive. However, the specificity, the sensitivity of NGS cannot be denied, and in ways it's the best overall platform. I don't know, George, how do you feel about that, and what are you guys doing at Dana-Farber?
Well, we're certainly using it in cases that we pick carefully. Again, I think it's expensive if you have something that you really have a very low likelihood. It's being widely used. I think it's a standard to use NGS for, let's say, non-small cell lung cancer. There are so many targets that you're looking for there. EGF receptor mutations, ALK fusions, TRK fusions. It makes perfect sense to do that kind of thing in lung. It makes perfect sense to do it in sarcomas. I think we get some pushback in some other diseases like GI cancers. But Alex, how about Memorial Sloan Kettering? What are you guys thinking about using technology there?
Yeah, I agree with Brian. Next generation sequencing really maximizes the likelihood of detecting these fusions. Obviously, you need to consider the resource context for the particular cancer type. You will have coverage for lung cancers where you have one big test that looks for a bunch of different things. But then in other histologies, especially if the frequency is low, you might want to consider a screening approach with IHC, then followed by orthogonal validation with another assay. I know, Brian, you're going to talk about this in a second, but I think that if we're looking for the best possible combo to detect a TRK fusion, then what we've done is we've relied on RNA, the Archer assay that Brian mentioned, in cases where we don't find anything on DNA-based NGS and we suspect we might be missing something. And certainly in lung cancers that are quote-unquote driver negative, we've run the Archer assay and found not only TRK fusions, but a variety of other fusions, including ALK, ROS, and RET, and also events like MET exon 14 skipping, which George alluded to earlier.
Yeah, and I think just to riff off of that, Alex, I do think it's important for people out there who are thinking about strategies for detecting TRK fusions that in cancers with known common fusions or known common drivers. I work a lot on GIST, which has, as George mentioned earlier, KIT and PDGFRA mutations. I wouldn't go immediately to TRK fusion as my first, the first thing I'm going to do. I'll rule out all the known genetics usually at first, and then I'm left with a case that I think might be a GIST, but it doesn't have any known drivers. That's the case that I'm going to look for TRK fusions. It would be the same thing in lung cancer, where you would look for all of the known events, and then maybe you get to the fusions at the end. Of course, at Sloan Kettering, you would look at ROS and ALK and TRK fusions simultaneously with this broad platform that looks for fusions. Okay, let's go to the next slide. All right, and this is just a schematic of how NGS works. On the left side of this slide, you've got point mutations as designated essentially by this line of C. And essentially when you make a next generation sequencing library, you're shearing up the DNA. If it's RNA that's been turned into DNA through reverse transcriptase, you do the same thing. You're shearing it up into various, it's random. And so you end up with a library of let's say a given size, maybe 80 to 100, couple hundred bases. But the sequences are not identical, and so they end up overlapping through bioinformatics. And that's what's depicted here on the left, where you've got a bunch of things of different sizes, and now you're picking up this mutation, which is overlapping. On the right side, you can look at homozygous deletion, hemizygous deletion, gains as copy number alterations. However, really this case is showing a translocation. And so on one side, you've got this yellow gene, and it's fused to something on the right side, which is this purple gene. And it's just the same principle. These are sequences of varying, generated randomly in a library. They're sequenced. And then using bioinformatics, they're all overlapped to determine where the translocation breakpoint is. And it's designated here by this dotted line. Let's go to the next slide.
I think you're right, Brian. NGS scares a lot of physicians because they think it's so complicated, but it's just a big bioinformatic jigsaw puzzle, right? I mean, basically the picture comes out with those little pieces get put together.
Yeah, and I mean, as pathologists, we try to put things in the simplest way possible. So I don't need to explain all of the details of how we do NGS to somebody to be able to communicate that, in fact, we've identified a fusion. We know exactly where the breakpoint is. We know what the 5' partner or the N-terminal partner is. We know what the C-terminal partner is. And based on all the information that's been generated, we can tell you with pretty high reliability whether we think it's a good candidate for you to take forward and do, for instance, TRK therapy on. And so, yeah, that's the goal. But it's, you know, the nice thing about NGS is you're piling a lot of technology. It's very, very powerful into a very clinically actionable methodology now. So, you know, this is precision medicine, and this is what we've all dreamed about doing our whole careers, and we're doing now. Just another example today with TRK fusions. So this slide here compares DNA versus RNA-based NGS approaches. And so DNA approaches are used mainly in the context, there are some exceptions of some of the libraries that come out from Illumina and so forth. The problem with, well, you can definitely detect fusions by DNA, but the problem with DNA-based technologies is introns. And so if you have a short intron between a couple of exons and the introns always get processed out in the RNA, then you can find the fusion. However, if the introns are big, you will miss fusions using DNA-based technologies because essentially you just can't get a PCR reaction that's big enough to jump across a large intron. And that will cause losses. You can circumvent that by tiling with a number of probes across an intron, but again, there are issues. If the intron's too big, you just can't do it. The beauty of RNA, which is on the right side of this, is that the introns are spliced out. You get rid of the introns, the fusion products tend to be much smaller, and they're easier. Essentially what you're doing is NGS-based multiplex PCR here, and so the introns are gone, and it's way easier to detect all of the different fusions you might see. And so most people who have seriously look for lots of fusions all the time will at least use an RNA-based fusion process at the end. I mean, at Sloan Kettering, I know they tend to do their initial DNA-based screen, which will pick up some fusions, but again, they'll end up with an Archer-based fusion platform to detect fusions if they don't see them based via the DNA sequencing and they think that they're still there. Alex, is that correct? Did I say that right?
Yeah, that's right. And I think the beauty of the Archer platform or anchored multiplex PCR is that it doesn't really matter what the upstream or 5' event is or how long it is, meaning that in addition to looking for fusions that we've already heard about or been published in the literature, there's also, in a way, a discovery element because you're in a position to pick up new events of different lengths. So it really maximizes the likelihood of picking these up if you're looking for these fusions.
Yeah. And I mean, we're discovering a new fusion almost every week, and I know you guys are too.
Yeah, absolutely. And as we've intimated before, it extends beyond TRK. Lots of fusions, like George mentioned in the beginning, can lead to oncogenesis. And so we're seeing a similar paradigm for ALK fusions, RET fusions, ROS1 fusions, and NRG1 fusions. So lots to learn, I think, diagnostically from the TRK program that we can apply to other oncogene-driven cancers.
Yeah.
And I think we really need to keep stressing that this is going to be part of routine practice. You bring up the challenge of cost, you get up the challenge of having to send it out to a reference lab. But honestly, I don't think you can practice top quality medicine, certainly not in non-small cell lung cancer, without doing this kind of screening anymore. I think that's just standard of care, best standard.
Yeah, absolutely. The era of precision medicine is here, and it's up to all of us to embrace it and use it in our practices. Okay, let's go to the next slide. Okay, so I mentioned it briefly that there's DNA-based panels, and shown here is a typical very large panel with a huge gene list. And essentially the take-home point is that NGS is probably the most efficient method for capturing TRK fusions, particularly in settings where pretest probability is low. And so with these big panels, you can capture virtually everything that you'd want to capture that would potentially be actionable. Let's go to the next slide. Okay, and then shown here are the ESMO recommendations for detection of NTRK gene fusions. They actually published a nice paper, which is a summary of a lot of what we know about NTRK fusions. And it's not just about pathology, so there's oncologies in that paper as well. And I do recommend it. I think it's a nice read. It's well written, and it's pretty authoritative. Here we're looking at one of the figures, which basically is a schematic diagram of how we would work up NTRK fusions. And so in the middle, you've got the blue diamond. And so if the histologic tumor type is known to harbor highly or recurrent NTRK fusions, then you could do FISH, which would certainly verify the diagnosis. It's not I don't think this is the kind of tumor where you do immunohistochemistry, because you know with high probability it's going to have an NTRK fusion. And again, I've emphasized that IHC, and at least in my view, is mainly a screening tool. If you have a sequencing platform like we do, we would go straight to sequencing. We wouldn't do FISH, but if you only have FISH, this is a good time to verify the diagnosis with FISH. And as George said, I mean, it's the standard of care now. If you think you have a case of congenital fibrosarcoma, if you think you have a case of secretory carcinoma, to verify that genetically. You don't want to just call it without verifying it, because it does have important implications clinically. Now, if the answer is no, it's one of the cases that is not known to have a highly recurrent NTRK fusion, then I think you would move towards a sequencing platform. Now, if you don't have a sequencing platform, as I mentioned, you can use IHC as a screening tool. It's very sensitive. It may not be as specific as originally touted, but that's okay, because it's going to pick up, you can at least screen out the half of the cases or more that are not going to have any NTRK signals, and then move towards NTRK sequencing with NGS. And NGS, as we've discussed, is the preferred way to do this. I would recommend just going straight to an RNA-based fusion panel. If you don't have that and you've got another kind of DNA-based panel, by all means use it, but RNA would be the preferred mechanism of doing the sequencing for all the reasons that we've discussed. It's a discovery platform, it's easier, it's more sensitive, and it's just better in this particular area. Now, if you've used IHC as a screening tool, following over sort of on the left side of the bottom of this, and you've picked up something and it's positive by immunohistochemistry, I do recommend verifying that by genetics. And again, you would use NGS-based RNA sequencing if you have it. You can always do it as a send-out as well to verify the diagnosis, because the specificity is not 100%. It's probably not even close. It's to being 100%. And so you'd want to verify that genetically, especially in the area where that patient is likely going to be moving towards some sort of targeted therapy. And we didn't mention it, but targeted therapies are not cheap and they come with side effects. We're going to get to that later. And so you really do want to be, I mean, the message that I could try to put forth here is that you really want to be sure that you've detected an NTRK fusion genetically. You understand what that fusion looks like if you're planning on treating the patient with a kinase inhibitor that targets TRK. Okay, George, do we want to talk about case study number 1 now?
Yeah, well, I think this brings to bear, I'm happy to do that with you, Brian, because this brings to bear, how do you approach patients clinically? This was a patient that got sent to us from out west in the United States, and the patient came to Dana-Farber with the outside diagnosis of a resistant GIST, but the peculiarity that there were no detectable mutations in KIT or PDGFR alpha, which happens in about 85%, which happens in about 15%. 85% of GISTs will have KIT or PDGFRA mutations. About 15% will not have those mutations. But then when our pathologist took a look at this, and our pathologist trained you when you were here at Dana-Farber, Brian, does this look like a GIST to you? He said, what do you think? But I'm not going to tell you what he said. What do you think?
This does not look like a GIST to me. I mean, you do get some crazy looking things that come out after multiple lines of therapy that may have been GISTs at one time in their life cycle, but certainly when they escape multiple lines of therapy, they can look pretty ugly and they don't look anything like a GIST. So yeah, this doesn't look anything like a GIST to me.
And that's exactly what he said to me. And this was not a patient who had been on imatinib and sunitinib for 10 years or something where those dedifferentiated GISTs show up. So this is, go ahead, go forward one slide. This actually basically got called an undifferentiated sarcoma with that kind of pleomorphic look. The cells don't look anything like each other. So yeah. we then actually did this. So what does this show you?
Yeah, so here's a typical immunohistochemical study with a pan-TRK immunohistochemistry, and brown is positive when we look at immunohistochemical stains. You can also have red sometimes, but this is brown, and I think everybody here that can see that there's, it's diffusely and strongly positive. The paler cells that you can see here are not neoplasm, and so serves as a nice internal control actually in this case, which is really a beautiful stain showing diffuse and strong positivity. This is a case now that I'm going to want to sequence, George.
Yep, which is what we wanted as well, so we sent it to the sequencing lab. And this was the result that came back. We actually did a control trial. We sent some to our internal sequencing folks and some to a reference laboratory, and they both came back with this result within a day of each other. I was trying to see who might do it faster, and it turned out that this is what we got, a TPM3 NTRK1 fusion. So that told us they have a TRK fusion, but it also came back with something else. Just like Alex Drillin said, you see so many things when you do next generation sequencing. We actually saw another problem in the genome of this tumor, which was a P10 truncation. So we didn't know what that meant, but at least we did know that the TRK fusion was positive. And at that point, we approached the patient about an investigational, at that time, therapy that was targeting TRK fusions. So we'll come back to this patient later, but I actually think now might be a good time to bring in Alex to tell us about the evidence base for TRK fusion inhibitors and what they do in different kinds of cancers, because it's, I think, one of the best stories of precision cancer medicine around. But Alex, we're going to turn this over to you now.
Thanks, George. Moving to targeted therapy, as you mentioned, this has really been a game changer for the field, and in many ways has reshaped our thinking about how to run clinical trials for some of these driver-positive cancers. And let's begin with surveying the field of what's out there in terms of targeted therapy. Here we have a table showing us both the first generation TRK inhibitors, those are larotrectinib and entrectinib, and the next generation TRK inhibitors, repotrectinib, formerly TPX0005, or selitrectinib, formerly LOXO195. You'll see that the first generation TRK inhibitors, laro and entrectinib, are currently FDA approved for the treatment of TRK fusion positive solid tumors in adults and pediatric population. But it's also important to know that we have regulatory approval outside of the United States, in countries such as Japan, for example, and in Europe. And hopefully we see the approval of these agents by more regulatory agencies as we move forward. So let's take a deeper dive and look at the first generation TRK inhibitors, and we'll start with larotrectinib. Larotrectinib is unique in that it is a selective inhibitor of TRK A, B, and C. This is in contrast to entrectinib, which we're going to get to in a second, which is a multi-kinase inhibitor that inhibits other kinases apart from TRK A, B, and C. You'll see here on this slide in the first bullet that the IC50s of this drug are very low, meaning it's very potent against these targets. And you'll see on the kinome dendrogram on the right that it pretty much only inhibits these three kinases, but not much else if you look at that tree. And then lastly, in the center here, you see that the drug not only has an oral pill-type formulation, but also has a liquid formulation for pediatric patients. Now, let's look at the larotrectinib development program. And it's important to keep in mind that this regulatory data set spanned 3 different trials. On the left, you'll see there's an adult phase 1 trial, a pediatric phase 1 and 2 trial, and then there's a Navigate adult and adolescent phase 2 basket trial. So we'll pause there for a second and consider that term basket trial. And certainly this goes back to what George said earlier about the long tail of these genomic alterations, meaning that you can find these drivers in multiple cancer types, some of them at high frequencies and many of them at much lower frequencies. But the strategy of the basket trial really tries to capitalize on that by designing the program so that patients hop onto the trial as long as their cancers have the genomic signature of interest and it really doesn't matter what the cancer looks like under the microscope. And obviously, the readout of an endeavor like that can take two major forms. Either you'll see that the context or the particular lineage of the cancer can affect the response to targeted therapy, but also an alternative happy ending, if you will, is that you may see tumor agnostic activity, meaning the targeted therapy works very well across different cancer types. So here in the larotrectinib program, moving back to the slide, you'll see that there were 55 of these TRK fusion positive cancers that were accrued of different cancer types, and the primary endpoint of this combined analysis was objective response rate. So looking now at what types of cancers we're able to get onto the program, here you see representation of those very common cancers. I should say cancers which are enriched for these TRK fusions. They're actually rarer cancers with a very high frequency of these TRK fusions. And here you have the salivary gland cancers, including the secretory carcinomas we spoke about. Here again, you see the infantile or congenital fibrosarcomas. And then beyond that, you have these much more common cancers where these fusions are harbored at lower frequencies, including thyroid, colon, lung, melanoma, so on and so forth. So what's the top line activity here? You see that responses were achieved in a very high proportion of patients. By both investigator and central assessment, you see that the objective response rate was 75% or greater. And you'll also see that there were many complete responses that were achieved, anywhere from 13 to 16% if you go from central to investigator assessment. And then lastly, really a low fraction of primary progressive disease. That's best visualized here in the waterfall plot. And here I'm going to point out that we're looking at an expanded data set. So beyond the initial publication of 55 patients, now we have more than 150 patients with TRK fusion positive cancers that were treated on the program. And here, each cancer type is represented by a different color. You'll note that the majority of patients had nice disease regression of their target lesions. And on the right, many had complete, very deep responses to targeted therapy. Now, I'll bring Brian in a second, because interestingly, on the very left, you see that there were some patients where we learned that the drug did not work. And interestingly, some of those cases were these equivocal calls on next-generation sequencing, where maybe the reference test said that, oh, there's a rearrangement, or I think we're seeing a fusion, but we're not sure if that's significant or not. For some of those cases, actually, we did exactly what Brian suggested in the ESMO slide, where we then looked at whether or not the protein was expressed. And for some of these primary progressors, we saw the absence of pan-TRK IHC staining. So Brian, what do you think about that? And what does that say about making sure we look carefully at these reports?
Yeah, thanks, Alex. I mean, you know, these fields are interesting because, I mean, in reality, we're talking about rare events in cancer. These are not common. Sloan Kettering's putting together a series and it's 100 plus cases. That tells you that this is rare. And so we're always in learning mode. And what we're learning are that not every fusion produces not every gene fusion produces a functional fusion protein. And so I think some of the things that you guys found in this particular study, they sort of look a little bit like cryptic fusions that may not be meaningful. And so I don't think it means that we go ahead and screen every fusion, every gene fusion that we detect with NGS, especially if it's known to be a responder, like ETV6 and TRK3. We don't need to investigate that. We know that's going to be a responder. It's a common partner, and it doesn't need to be verified. However, for instance, if you detect a fusion now that's unique, something new we haven't seen before, that might be a situation where we go out and do immunohistochemistry and look now, knowing really based on your study that since some of these things aren't produced, that we would screen with immunohistochemistry, and if the protein is not being expressed, I think we can infer that it's probably not going to be something good to target, and maybe it might even explain a failure. I don't know if I would not treat a patient based on that. We can get George's take on this. But certainly I think immunohistochemistry could be very useful in this setting to verify that the gene fusion is being expressed and that it can be detected.
Yeah, and let me comment. I'd like to comment on that too, Alex, because we've seen the same problem in a small number of cases where the report comes back, there's a very noisy genome, so there's a lot of break aparts, and we think there might be a fusion, but we're not sure because it's not a standard one. And I think that's a red flag that just what's going on here. Just because you've got noise in the genome and bits of chromosomes are coming together doesn't necessarily mean that a productive fusion protein is going to be in that tumor driving it. And the important thing I think to take away is it might be useful to screen with IHC if you can get it done quickly. What I worry about is people who are screening with DNA might then push to take time to get the patient screened with RNA, and that takes weeks. So the other thing to do is just potentially give the drug, but don't expect it will work, because this explains drug failure. And I think it's a very rare thing, but these drugs are so potent. Look at that beautiful waterfall plot. We've all seen this. And those few on the left side where the tumor just keeps growing, that can be explained by the fact that the actual driver fusion protein is not there. So how we deal with that in practice may differ between centers, but it's important that it's explainable.
Thanks, George. And I think just to circle back to something that you underscored, definitely we're seeing a very high rate of activity here. And these situations are very rare where you might have a fusion that's not quote unquote real. What I wanted to bring out is just making sure that when you look at a report, you pay attention to how it's worded. And sometimes the test will actually call out that they're not sure about a certain event. And to take that one step further, I've actually, and George and Brian, you've probably gotten inquiries as well about NTRK mutations that pop up. And they're like, all right, so let's go ahead and give entrectinib or larotrectinib. Have you seen that question come your way?
All the time. All the time, both of us.
And we know that they're not going to respond in a general way, because they're probably silent mutations or mutations which aren't consequential. And we look at gene fusions as being meaningful in this setting, not point mutations, not missense mutations, not deletions, insertions, etc.
Right. Wonderful. All right, so let's move on. So we've seen response, but what about durability? And so here on the right, you see the Kaplan-Meier curves of duration of response and progression-free survival. And in this updated data set from larotrectinib, we see a phenomenal median of almost 3 years in terms of a duration of response, and a median progression-free survival that well exceeded 2 years. So really fantastic outcomes, and highlights the fact that when you have a good match, you find the fusion, you get a patient on targeted therapy, they can stay on that therapy for a very long time. Now, another question that often comes up is, are these drugs active in the CNS? Knowing that some cancers, like lung cancer, these can have a proclivity for brain metastases. And so here we have a case showing that there was a glioblastoma, pediatric glioblastoma, that was found to have an NTRK fusion. And this patient was treated with larotrectinib, and she did have both a clinical and radiologic response to therapy, showing that the drug can get into the CNS compartment. Now, we'll pivot for a second and talk about the other early generation TRK inhibitor, and that's entrectinib. If you remember, I mentioned that this is unique and it's a multi-kinase inhibitor, and you'll see that in the table on the lower left, where you'll note that in addition to TRK A, B, and C, the drug is also very potent against ROS1 and ALK. And in fact, as a bit of a sidebar, entrectinib was also approved for the treatment of ROS1 fusion-positive lung cancers that hadn't previously received a tyrosine kinase inhibitor. And here you'll see the X-ray crystallography of entrectinib binding very nicely to one of the TRK proteins, TRK. And what that does is, similar to larotrectinib, it helps shut down the oncogenic signaling that you see on the right. Now, moving on to the regulatory data set of entrectinib, Dr. Dimitri is very familiar with this. He was the senior author on the Lancet Oncology publication. Here you see that the first thing I'll point out is, if you pay attention to the table on the left, you'll see that this data set was only in adult patients, even though the entrectinib program has presented their pediatric data. So you have an age range of 21 to 83 versus the prior data set, which had an age range down to less than 1 month, meaning we had infants that came onto the program. And then here on the right, you'll see a slightly different profile of the most frequent cancer types. You have sarcoma, that was the most common, followed by non-small cell lung cancer, then secretory carcinoma of the salivary gland, breast, thyroid, etc. The last thing I'll point out is that we do have a little bit more data on CNS outcomes with entrectinib, just because there were more patients with baseline CNS metastases prior to treatment that made it into this data set. And here you'll see that in the table with about 22% of patients with baseline CNS disease. So looking at the waterfall plot, again, you'll see very similar to larotrectinib. Most patients had disease regression with therapy. In this particular plot, we're looking at color coding by whether or not patients had baseline CNS metastases. So you see the orange bars are patients that did have intracranial disease versus the dark colored bars with patients that did not. And you see that overall responses were achieved in both populations, highlighting that this drug can control disease everywhere, including the central nervous system. And then finally here we see color coding, this time by the different cancer types. Again, nice deep responses on the very right. Complete responses were achieved in several patients, and most patients had disease regression for an objective response rate of 57%. Now, we've showed you that these inhibitors can work very well, and they can work for a very long time. So that begs the question, how safe are these TRK inhibitors? And we'll get to that in this slide, which shows us the safety profile of larotrectinib. And you'll see that on the left, it's a bit of a busy slide, but there are many treatment emergent side effects that we see across different tyrosine kinase inhibitors, such as fatigue, nausea, constipation, transaminitis, etc. I think that in interpreting this, for me, one of the best metrics of tolerability would be the frequency of dose modifications. And you see that in the footnote below, where you'll note that 9% of patients, so a low number, required dose reductions on larotrectinib, and less than 1% actually had to stop the drug due to an adverse event. So overall, these drugs are very tolerable and are amenable to chronic administration. We're seeing similar things here with entrectinib, and I'll turn to George in a second as he has a lot of experience with this. But again, the side effects that you see here, not very different from those that you see with larotrectinib. And then on the right, you see the rates of dose reduction and dose discontinuation. George, tell us your thoughts on how these patients did when they were on therapy.
I think we are blessed with two very well-tolerated drugs. You know, the oncology literature is almost poisoned by that phrase, well-tolerated, because everybody uses it liberally, even with drugs that cause chronic diarrhea or other things like that. This drug really is, as you know, Alex, is very well-tolerated. The same thing with larotrectinib. So I think both of them have very similar tolerability, which is a fascinating thing. If you go back to the 1990s, people were nervous about developing drugs of this class because they were very worried about the CNS side effects. because of the development role, the role of these proteins in maintaining a certain amount of CNS and propagation function. But it turns out that they are remarkably well tolerated, these two first-generation drugs. And I think that's what we learned from this. Very few people had to have dose reductions or come off the drug. And remember, this was a sick population in these studies. These are patients who had brain metastases often. This was not well cancer patients, shall we say.
Yeah, thanks, George. And I'm going to turn to Brian for a second, because we kind of intimated that the TRK pathway is involved in the development of the nervous system. What do we know about the TRK proteins in normal biology, Brian?
Yeah, so TRKs, I mean, they're expressed pretty, not completely exclusively, but certainly have a predominance of expression in nerves and muscle. And so, you know, nerves would be the most probably prominent thing that you'd really be worried about the most. But yeah, again, I mean, I'm always struck that on paper things look like they might be pretty toxic and you really worry, but I always think the proof is in the pudding. When you get it into patients, how safe is it? As a pathologist, sort of wannabe oncologist, when I look at this sort of data, I'm struck by the low number of grade 3 and grade 4 toxicities. That's what I look at, because I know those are things that usually require stopping giving the drug. The grade 1 and grade 2, I think that all the oncologists I know are just brilliant at treating all of these low-level toxicities. It's the grade 3s and grade 4s which are the drug stoppers, and I don't see a lot of that here.
Yeah, absolutely. And certainly that's the same across the board when you look at larotrectinib. And I wanted to pick up on something that Brian mentioned, that these TRK proteins are expressed in the nervous system because there are, while they're not very common, some unique side effects to watch out for when you're giving these early generation TKIs, larotrectinib and entrectinib. And because the TRK family is involved in nervous system development and maintenance, we're seeing things like dysgeusia, dizziness, knowing that the drug can mediate proprioception because it's expressed, TRK is expressed in the cerebellum and in the spinal column. And other things such as paresthesias. These tend to be mild and strangely perioral and can go away within the first month. But the last thing I'll point out is here on the left in this table, you see weight increase. And that's mediated by one of the TRK proteins, TRKB, which we know controls thirst and appetite. And in some patients, you'll see it can be a little insidious, but the appetite can increase over time. And weight is something we have to monitor because we do see weight creep up in several patients on both drugs. George, do you have experience with any of these unique side effects that we see from these drugs?
We do, and in some patients who have, if not cancer cachexia, at least a problem with eating, these drugs can reverse that, just for the reasons you say. I think it is an on-target effect, and it can be very beneficial in some thinner patients, and I certainly don't want to scare any patients off of this. We just make them aware of it, that it could stimulate their appetite if they are worried about becoming obese. That might even be a good thing, but we can control that, I think.
Absolutely. And that really summarizes our state of knowledge on the activity and the safety of these TRK inhibitors. I think this is an opportune time to jump back in and look again at that case that George presented and see what happened.
Well, so thanks, Alex. And this patient signed up for the clinical trial we had at the time. Our principal investigator here was my colleague Anna Farago over at the Mass General, but we had it also at Dana-Farber. She went on this drug early on, and remarkably, within a month, was feeling much better. Her tumors went away. It was really quite amazing. She did not achieve a complete remission, but a major symptomatic improving partial remission. And basically, after 2 cycles, she had a beautiful response. I don't have the cycle 2 scan here, but trust me, she had a partial remission. And that lasted for her a good 9 months or so before resistance crept in. And that's one of the other things. We expected with any kinase inhibitor that resistance could eventually be a problem. And so this patient then had resistance. We actually, and you actually, with some of your work, Alex, could predict where the resistance would show up in the kinase. The science is so good, we can actually predict why these drugs might fail. And so we took out one of her resistant lesions and we studied it. And in fact, we knew she had a resistant site that might be sensitive to a second generation drug. And Alex, let me go back to you. And you have a similar patient who developed resistance on a first generation drug, I understand.
Absolutely, and we're looking at that case now. This was a different cancer type, again, one that's enriched for TRK fusions, these secretory carcinomas of the salivary gland. And this was a patient who came to me from China. Because of the histology, we did sequencing, found the ETV6 and TRK3 canonical fusion, and initially put him on entrectinib. He did very, very well for more than 2 years. And unfortunately, as often happens in metastatic disease, the cancer progressed again. And like you did, George, with your patient, we took a biopsy, especially of this tumor that was easily accessible externally, and found one of these kinase domain resistance mutations. And we know that these mutations, similar to other resistance mutations that have popped up for other cancers, they can interfere with drug binding. And so what happens is it becomes harder for the first generation drugs, larotrectinib and entrectinib, to fit very nicely in that binding pocket to inhibit the TRK fusion proteins. And so thankfully, the structural chemistry field has advanced substantially. And we've been able to develop smaller molecules that really zip past that blockage that is mediated by the acquisition of these mutations and then fit nicely again into the binding pocket, thereby inhibiting these proteins even in a resistant setting. And I know you've been waiting with bated breath because we previously mentioned both repotrectinib and selitrectinib. And this is an example of a patient who did very well on a pill, developed progression. We found the right signature, put him on a second pill, and here we see the very fantastic results. You see the tumor melting away within the first 3 cycles. And on the right, you see PET scans, which show that the activity or the metabolism of these cancers that was really shut down in addition to these tumors shrinking. I think this is great for patients, and it highlights the utility of hopping onto a second generation pill after benefiting and progressing on a prior one. So George, what do you think? I think this is good news for patients.
This is wonderful news for patients. And our patient, after developing resistance on the other TRK inhibitor, larotrectinib, after almost a year, was lucky enough to be one of the first 5 people in the world to get selitrectinib, then known as LOXO 195, which she's now been on for more than 3.5 years with a beautiful response, living normally, essentially no side effects. Again, just like you say, a little bit of dizziness at the start, and that's easily managed through. So now, actually, that went away. She is perfectly normal and very thankful that she has access to these effective therapies.
And you guys didn't say it. Yeah, sorry to interrupt. You didn't say it explicitly, but this also highlights a very interesting biology of fusion-driven cancers, and they are oncogene addicted. And they are driven almost exclusively by a single genetic event. And so here, what this illustrates is that even though the fusion has become resistant to the primary drug, that fusion is still the driver, it's still the target. And you can come in with second, third line, presumably, fourth, fifth, etc., line inhibitors down the road, and it's really unusual for these tumors to switch off of their primary driver. They will do it eventually. We learned from GIST, for instance, but it takes a while, and you can go through several lines of therapy before that happens.
Yeah, and I want to come back, Alex, let me come back also to my patient that I just talked about. Remember, she had that P10 truncation. So we were worried that she was P10 deficient and might have too much PI3 kinase signaling pathway. When she first went on larotrectinib, I told her, this might not work. You might have a bypass route for resistance built into your tumor. But just like Brian said, fusions tend to be dominant drivers. So that PI3 kinase signaling, we overcame that with a TRK fusion inhibitor, and now clearly with a second generation fusion inhibitor, she's not having any problems. It's a remarkable thing. This has been a great discussion. I think it really highlights the interface between the diagnosis, the available drugs, and the practicing physician. So I'd like to, on the next slide, I'd like to really go to this issue that are takeaway messages and ask Brian what he thinks about this from pathologists. Brian, you're a very famous academic pathologist at Cleveland Clinic. You run pathology for centers in Dubai and London, as well as Cleveland. What should pathologists take home about this? They come in many types, right? Community pathologists are very, very prevalent. Academic pathologists are incident.
Yeah, I mean, the first thing is people are going to have varying tools. That doesn't limit your access to precision medicine. And so if you don't have immunohistochemistry for TRK, if you don't have access to NGS or FISH, don't let that limit you. My message would be reach out. There's a lot of academic pathologists who do consultation pathology and can do the full gamut of testing to verify these unusual cases. And we're happy to see the cases. We use them to educate our fellows and the future leaders of soft tissue pathology and other areas of pathology. So don't let the fact that you don't have a tool limit you. We get cases, for instance, we have a pathology in Abu Dhabi, and they don't have every tool, but they send us cases and we help them occasionally, and we would do that for anybody in our system. We also do it for a variety of places that are not academic and just don't have as many tools as we do. So that's the first message. The second is that if you're going to look for TRK fusions, I would say that there's we showed the slide before, but if it's in a type of cancer that doesn't have a high prevalence of these canonical mutations, then you can use IHC. It's a good way, and it's good to use, and it's a good open-ended assay to look. If you know that it has a high group of fusions in it and it's common in that kind of cancer, I think FISH is good, but I really like NGS. It's an open-ended assay and it provides a lot of information. If you're wrong and it doesn't have an NTRK fusion, then you might find something else that's also very, very, very useful. The second point is that these NTRK fusions are likely to be mutually exclusive. And so in cancers with known genetic alterations, it really doesn't make a lot of sense to be looking for TRK fusions. Also in cancers that are known to have common alterations like BRAF mutations in melanoma, for instance. Look for BRAF first. If you end up at the end of the day, you've done a lot of genetics, you've still got a melanoma, it doesn't have a known genetic alteration that you've looked for, it might make sense to look for NTRK fusions or a variety of other cancer-causing mutations using a very open-ended platform. But certainly exclude the more common mutations first if you can. And then just the last point is, as shown here by Alex and based on our discussion, you can see that when a cancer has a TRK fusion, a known TRK fusion, it's very likely that it's oncogene addicted, that fusion is driving the pathogenesis, the oncogenesis in that cancer, and so it's likely going to be responsive to an NTRK inhibitor. And I really think these are such home runs for us as people who study cancer that we want to really identify as many of these patients as possible because they respond so well. So everything we should be doing is trying to focus and find these patients and then move them onto oncology where they can be treated with an appropriate drug.
And Alex, clinical oncologists, what should they know? Clearly your data are very compelling here.
Yeah, so thanks, George. I think that the first take-home message here is that the approval of these drugs was really paradigm changing. We've now validated that the strategy of studying targeted therapy based on the driver in someone's cancer, but agnostic of what the cancer looks like under the microscope, that in select situations it can work very well. We've also seen that with immune therapy. We know that there is a pan-tumor approval of pembrolizumab for MSI-high cancers, and then most recently for TMB-high cancers. So I think that as a field, we're moving in a direction where we have the freedom and the ability to explore the tumor agnostic question. I think from practical perspective, as Brian pointed out, these pills work very well. So it's really worth it to look for these TRK fusions. And one personal message really is that I wouldn't be discouraged by the low frequency that you see on paper. George pointed out that for lung cancers, while you might have a frequency of less than 1%, when you have more than 250,000 annual cases in the US alone, that can add up to a substantial number. And even in other cancers where the frequency might even be lower, we've certainly seen that when you find these, even though they're rare, it can be absolutely meaningful for a patient. It can change their life, turn things around, bring them back to how they were functioning formerly, and control their cancer for a very long time. And that's also considering that, as we discussed, the safety profile of these drugs is very favorable. It's very likely that you can keep your patient on a good dose of the drug for a very long time. And like Brian said, it's really a home run. It's a win-win for everyone.
Well, I want to thank you both for just a great discussion on this topic. And to everybody out there watching, I think what you've seen with TRK fusions as a paradigm example is that through research and understanding what's really driving cancers, we can then make an accurate diagnosis and then treat the underlying cause of that cancer with new drugs, and then even come up with drugs to reverse resistance, hopefully on the way to figuring out how to cure these people. But in the meantime, being able to give them really high quality life and good quality tolerability by targeting TRK fusions. And all of this relies upon our interaction as clinicians with our pathology colleagues to have the most accurate diagnosis of whatever it is the cancer we're treating is driven by. And what's fascinating is that it doesn't matter if it's a lung cancer, a GIST, a cholangiocarcinoma, or many other kinds of tumors, including brain tumors. If there's a TRK fusion there, we're seeing that as the driver. And now we know we have these highly safe and effective therapies that can really be useful for those patients in a very significant way. Brian and Alex, I just want to thank both of you for participating in this discussion. It's been terrific.
Thanks a lot, George. Yeah, this was precision medicine at its best. Really enjoyed our conversation. Thanks.
Likewise, it's been my pleasure. Thanks a lot.
Thank you both. And thank everybody out there for joining us today. I hope you found this CME program informative and hopefully very useful for your practice. Bye-bye.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/DMK860. This activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals, Incorporated. This activity is jointly provided by Medical Learning Institute, Incorporated and PVI, Peer Review Institute for Medical Education.